Thank you all for joining this exciting event with the launch of the Global Implementation Society South Africa chapter. I am Mads. I am support staff for GIS, and I'm going to introduce our event host, our MC, Shlangiwe Gwebu. Shlangiwe is an educator, researcher, and mentor, and currently works as a senior lecturer in the public health department at the University of Fort Hare. She leads several collaborative projects on adolescent health and HIV, and co-leads research under the Global Parenting Initiative aimed at promoting positive parenting and preventing violence against children. Her scholarly pursuits are situated within the domain of implementation science, encompassing family strengthening interventions and adolescent health and rights, as well as policy and advocacy in the Global South. Through her work in these areas, Dr. Gwebu is committed to advancing social justice and enhancing community well-being. And with that, I will pass it to you, Shlangiwe.
Thank you very much, Mads. Welcome, everybody. Thank you for the introduction. I'm so excited to be your host for the day. Please feel free to use the chat session to also introduce yourselves. We would love to know where you come from, who you are, where you're joining us from. I'm based in South Africa, as Mads has said. However, I'm joining from the Netherlands today. So please let us know where you're joining from. So without further ado, I'd love us to look at the agenda for the day. So when you look at the agenda, you realize that we actually have two parts that we're going to be focusing on today. So firstly, we'll have a lineup of 3 amazing speakers who are going to be tackling different topics related to implementation science and GIS. And then the second part will be a panel session of 4 speakers that are going to be tackling implementation science as well on community level. So let's look first at our rundown from the beginning. So firstly, we're going to have an introduction to GIS by Dr. Naveen Aburumila, followed by building the GIS Africa Hub with Dr. Beatrice Wamoti. And then we have the role of implementation science in getting innovation into practice with Professor Linda Gale. After that, we're going to get into a panel session that's going to be led by my colleague, Jan Paul, on implementation science communities. And then lastly, we're going to have a wrap-up session and look at the future chapter development on GIS South Africa. Without further ado, thank you, Mads. I was just going to say that. Let's introduce our first speaker for the day. So firstly, we're going to have Dr. Naveen Aburumila, who is a professor at Qatar University. She holds a BSc in medical technology from Al Quds University and a Master of Public Health from BZ University and a PhD in statistical epidemiology from the University of Glasgow. She teaches a variety of courses on quantitative research methods, health statistics, and population studies. So Dr. Aburumila has been involved in multi-country projects at the national, regional, and international level. She was part of the WHO initiatives in encouraging implementation research in AMRO region, and her research interests are focused on the 3 broad categories, which is epidemiology of non-communicable diseases, multimorbidities, and reproductive health disease and evidence synthesis. She currently serves as the board president of the Global Implementation Society. Dr. Naveen Aburumila, over to you. Please take the floor.
Well, thank you very much for this introduction. And I wouldn't take much time from our colleagues, but I would like to welcome everybody, saying good afternoon, good morning, good evening for everybody, depending on your place, where are you from. Let me welcome you all, members and distinguished guests, to this very important event launching GIS South Africa chapter, which is with a great honor and enthusiasm. Let me give a quick introduction about the GIS. GIS, which is the Global Implementation Society, has a rich and evolving history. Its roots stretch back to 2008, when the Global Implementation Initiative was first conceived. In 2011, the Global Implementation Initiative was formally incorporated as a nonprofit organization, and the following years marked a major step forward with the first Global Implementation Conference in Washington, D.C. Between 2012 and 2020, the initiative grew in scope and vision, ending in the formal establishment of the Global Implementation Society known now. Global Implementation Society, GIS, was launched with a focused mission around the three core pillars: building a global society for implementation professionals, hosting the biannual Global Implementation Conference, developing robust educational resources to support implementation work across sectors. Since then, Global Implementation Society has become a truly global platform with more than 43 countries around the globe, members from 34 countries around the globe. The members include dynamic mix of researchers, practitioners, and scaling and facilitators, with experience levels range from beginners to advanced. The society purpose is clear: to promote coherent and collaborative approach to implementation practice, science, and policy, especially in human service sectors like health, education, social development. We believe that when effective implementation is prioritized, we see real-world outcome improve for children, families, individuals, and community. GIS supports its members through strategic committees, including the Professional Learning and Resource Committees, which are advancing educational opportunities, the Membership Committee, fostering regional and professional connections, Standards and Competencies Committee, defining the skills that drive excellence, and the Global Implementation Conference Planning Committee, which recently hosted the GIS 2024 in Abuja, Nigeria, in collaboration with the Nigerian Implementation Science Alliance. Another milestone was the launch of GIARA, the Global Implementation Research and Applications Journal, further anchoring GIS as a thought leader in the field. We started with a strong GIS LATAM hub and then Pakistan hub. With today's launch of the South African chapter, we expand the GIS footprint to one of the most dynamic and diverse implementation environment in the world. The chapter will serve as a hub of collaboration, innovation, and knowledge sharing, designed specifically to meet the needs of South African community and system. Let me end with this. Implementation is not a science or a process. It's a bridge between what we know and what we do, between policy and practice, between intention and impact. And through this chapter, we now build a bridge stronger and closer to evidence. On behalf of the GIS, the Global Implementation Society, welcome, and we are thrilled to walk this path with you. Thank you all.
Thank you very much, Dr. Abu-Ramila, for such a lovely presentation. It's lovely to see the milestones that GIS has actually walked through. We actually see clearly that it's been a journey. And looking at the South Africa chapter, which is just being launched or about to begin in South Africa, we actually appreciate you sharing such milestones. And we did say that we've got limited time today, so we will have a Q&A session at the end. But for now, please allow me to introduce the next speaker, who is going to be tackling GIS Africa. And this takes us now to the theme of the day, because we know that here we are about the launch of the South Africa GIS chapter. So I'm going to introduce Beatrice Wamuti. I'm trying by all means to make sure that we have time for discussion and engagement at the end. But thank you very much, Dr. Naveen Abu-Ramila. We really appreciate that clearer picture that we know where GIS started and the journey that you walked through. And it's amazing to see what has been accomplished within such a short space of time. It gives us hope that all chapters of GIS will be able to actually accomplish the goal of GIS. So thank you very much. Let me introduce our next speaker for the day, Dr. Beatrice Wamuti. So Dr. Beatrice Wamuti is a Takami postdoctoral fellow at the Harvard School of Public Health, with a PhD in Global Health Implementation Science from the University of Washington. In addition to that, she is a registered medical doctor with an MBA and MPH. She is passionate about healthcare system strengthening within low and middle income countries and has keen research interests in evidence-based clinical research, implementation science, and health systems management. Over the past decade, Dr. Wamuti has worked in HIV prevention, particularly HIV partner services, to improve case finding, diagnosis, and initiation of antiretroviral therapy among sexual partners to newly diagnosed HIV-positive individuals in sub-Saharan African countries. She also has served as a senior technical advisor for the APS Scale Up project, which is a collaborative study between the Universities of Washington, Perth, Kenya, and the Ministry of Health. She currently serves on the board of GIS as well as an associate editor for the Journal of GIS Global Implementation Research Application. Lovely to have you today, Dr. Beatrice Wamuti. Please take the floor. Over to you.
Thank you very much. And excellent day here. I'm very, very excited to participate in the launch of GIS South Africa. What we're trying to do here is to set up, as we set up the GIS South Africa chapter, introduce what implementation societies are all about, what we can do with this next chapter in South Africa, and also just give a bit of a background in terms of what we've done with GIS Africa as a region in terms of setting up the implementation society. There's the why implementation societies are important for Africa. We know that in general, Africa has lagged behind in terms of research in general and specifically for implementation science. And so there's the from to where we're coming from and where we're aiming to go towards. So in terms of networks, from fragmented networks in implementation science that really do not have any linkage to implementation, to a point where we can bridge the no-do gap in terms of implementation, so through knowledge sharing and cross-country learning. There's another point, which is over-reliance on Western frameworks that are not really tailored to the African context. And so for us, what we're going towards is developing context-specific solutions that are tailored to African realities. A third thing is the funding constraints and the resource realities that we do have right now. We see what's been happening, especially in the world of healthcare funding. And that reliance mainly on donor-dependent research is not really sustainable and very short-term. And so what we are moving towards is a more resource-efficient situation where we can have cost-effective implementation strategies that are tailored to the African context. A fourth thing we're thinking about in terms of the societies for implementation science in Africa is sort of the limited local research capacity, because we do have, and we do acknowledge very few trained implementation science experts on the continent. And it's not been, implementation science has not really been well integrated into academic structure. And so what we want to do is improve or strengthen local capacity so that we reduce dependency on external expertise and we really have local solutions to local problems. The fourth thing is understudied populations, which are often excluded from implementation science studies. Consider rural communities, the urban poor, conflict-affected communities. And so what we want to do is address inequities, social inequities, especially for such marginalized populations. So for the second point, why we formed the GIS Africa Hub, just for context, as Naveen has mentioned, we have GIS, and it was formed basically as a platform for developing a global network of implementation science practitioners and researchers. And so GIS Africa was launched in 2023. And this is part of several regional frameworks or hubs that we have for implementation science within GIS. So we do have one in North America, we have one in LATAM, one in Middle East and North Africa, one in Oceania and Australia, and as Naveen has mentioned, we also have one in Pakistan and also Latin America. So in terms of what we've done so far with the GIS Africa Hub, as a co-lead for this hub, we've had several webinars, and key of those is our focus has basically been to highlight research from the African continent. First of which was a collaboration with CICITRIS, which is Center for Clinical Trials and Implementation Research in Nigeria, And that basically was to show how programs work and how they've tried to tailor implementation science to the Nigerian context. The next was a webinar on the Senegalese context, so this is West Africa, looking at how implementation research training is done there. Another key conference that we had is the Global Implementation Conference that was conducted in Abuja, Nigeria last year in November. Again, trying to bring researchers from the African continent to come and highlight their work in implementation science. And then finally, earlier this year, we had a session with GIS Africa and GIRA, which is our flagship journal, the Global Implementation Research and Applications, of which I am an associate editor, trying to show the publication process and also trying to highlight that the fact that GIRA publishes work from both researchers and practitioners. And also we are trying to get research outside the field of core healthcare into many other fields. So think about education, think about agriculture. We do want the whole span of work that's been done outside just core healthcare into other fields. So my third point, which was why is GIS South Africa, the hub launch, such a vital chapter for the Africa hub in general? I think for us, it's very clear we do need to strengthen our implementation science networks. For us, I think the call to action from this call is to involve more researchers, practitioners, policymakers from South Africa, and also leverage your network so that we can have way more individuals from the Southern Africa region and also the global Africa continent to participate in GIS and GIS Africa specifically so that we can strengthen capacity within the continent. The next thing is to improve uptake of implementation strategies, methodologies, and frameworks to strengthen the work that we do so that they're more tailored to local context. And third is to improve sustainability. As I've mentioned, there is a lot of upheaval in funding right now, and the more we can have funding that's from our local governments, from our local institutions to develop, integrate, and sustain our interventions, the better. So for me, congratulations to GIS South Africa launch, and thank you so much for having us here, and we're really looking forward to working really closely as we move forward. Thank you.
Amazing. Thank you so much, Dr. Beatrice Wamoti. It's lovely to see the positive that's being shared, like the work, the milestones, the achievements thus far that are being shared. And it's actually all a testament of the team's effort in collective commitment and rigorous efforts in fostering global dialogue on implementation science. And I think that's why we are here, to bring all the players and practitioners in one room. That's where it begins, right? So we're really happy for that. And one thing that I really love that you emphasized on is the tailoring of the frameworks to suit the African continent, but also the specific countries in Africa. And that shows that there's actually room for innovation and creativity, that all the players that are actually going to participating in the South African chapter are free to actually bring their expertise to the table. And I love that, to say it's not a one-size-fits-all strategy, but it's work in progress to see where South Africa wants to take it. Nigeria probably has done it in another way, and other countries. And what you're doing is basically providing support for such countries to launch their own platforms on how to do things. It's actually interesting to see all of that. So thank you very much. At this point, I'm going to introduce Professor Linda Gale-Becker. So Professor Linda Gale-Becker is the director of the Desmond Tutu HIV Center at the Institute of Infectious Disease and Molecular Medicine at UCT, and the Chief Executive Officer of the Desmond Tutu Health Foundation. Prof. Becker is a physician, scientist, and infectious disease specialist. Her research interests include pragmatic and action research around antiretroviral rollouts and TB integration, prevention of HIV in women, young and MSM. She's also a PI of the NIH USA-funded UCT CTU, and remains actively involved in the work of the 4 associated clinical research sites in the 4 Dates network. She has led numerous investigator-driven studies in HIV treatment, prevention, and tuberculosis. Becker serves on numerous international scientific advisory committees and has served as the president-elect from 2014 to 2016 and the president from 2016 2018 of the International AIDS Society. She is an A-rated scientist and has published over 700 peer-reviewed papers. Professor Linda Gale, I'm honored to actually have you today. Please do take the platform. Thank you for joining us.
Thanks, Lingiwe. It's a real pleasure, and thank you, everyone. I was fascinated by the introductory talks, and to say that I'm going to talk about the role of implementation science. I'm now going to speak even faster in getting innovation into practice. And I am an infectious diseases doctor and a clinical trialist. But my understanding of implementation science is that it focuses on how effectively to translate evidence-based practices, research findings, and innovation into real-world settings such as our own, aiming to improve health outcomes by addressing barriers and promoting the uptake of effective interventions. And this is what I've spent a great deal of my career doing. Now, I do come to you from an HIV lens. I'm an HIV doctor. And I'm really concerned, along with many other people, that we are not on track to meet the 2030 UNAIDS targets. And the region I live in, the region we're talking about now for this chapter, really does bear the brunt of the AIDS epidemic. So more than half of the new infections occur in this region, of which predominantly are women. So more than 20 million of girls and women living with HIV are in our region. And the other half of the infections are particularly amongst key populations really all over the world. So this remains a global pandemic, and there's much work to be done in this regard. Now, not to say it's all gloom and doom. We really have had the triumph of treatment with almost now 30 million people on HIV treatment, and many, many lives have been saved as a result of this. Treatment as prevention is a very real phenomenon. So secondary prevention, now we know that people who are completely undetectable in their viral load are also uninfectious or untransmittable. In other words, they cannot pass virus on to their sexual partners if their virus is completely undetectable. And this has really introduced the concept of U equals U. However, as I've already mentioned, we are not yet at the place where every single person on the planet knows their status, is on antiretrovirals, and is virally suppressed. And so this means that there are still millions of people at risk of HIV acquisition all around the world. So we do need to think of both a prevention push as well as a treatment pull. And this enables both primary prevention as well as secondary prevention in order to get complete epidemic control. And we know this is possible because in certain cities around the world, they really are seeing a reduction in incidence and are moving towards viral control and lack of new infections. So our task as a global community, but certainly in this region, is to reach those missing millions. Who don't we have enough? Who has not tested? Who's not linked to ARVs? Who then has cycled out of care because we know that this is a dynamic revolving door? Who are the members of this community who struggle to suppress or not? Who have been tested but have chosen not to prevent, and those who've disengaged from prevention, or those who can't or won't attend health facilities for a variety of reasons. And we know that these individuals are out there and need to be reached. And we think about these hardly reached individuals as really needing us to go beyond traditional facilities into community, using innovation, resources, relying heavily on community. And I'm hopeful for the second part of this program today, because I think community is absolutely key. We've got to think of the stakeholders that are needed beyond health facilities. And it's probably going to take resources because we now have to reach up into the very highest branches of the tree. Now, the first 30 years of the HIV epidemic quite rightly, featured on treatment. It was all about survival and bringing down death rates. Now we can begin to think about, prevention beyond the sort of initial ABC, abstinence, be faithful, condomize, we can now think about having a pill a day to prevent HIV. And we do know today that a pill a day does in fact prevent HIV. The pill is FTDF or Truvada. It's taken once a day. And we know that in individuals who take it consistently, there is complete protection against HIV. But we have been slow in getting this new primary prevention out. And you can see that in 2020, we missed the targets, and certainly by 2025, we have missed the targets again and likely to miss the targets we've set for ourselves for 2030. This is how PrEP initiations, and this is initiations not necessarily people staying on PrEP, but this is how it looks around the globe, and this is how it looks in our region. So you can see South Africa has finally got out of the starting blocks. Other countries are catching up, as well as Nigeria. Very nice to see. Caution note here that much of this is thanks to PEPFAR. And of course, as you've already heard from Shlingiwe and others, that we are in a potential funding crunch in this regard. And it's we'll need to see what happens to these programs, if PEPFAR is either stopped or comes back in a much lighter form. So at the moment, for every PrEP person we start on PrEP, we have about 3 HIV acquisitions. So we're actually moving backwards faster than we are moving forwards. And this is beautiful work from Nora Rosenberg, which she looked at a series of surveys that had been done in our sub-Saharan region. And she worked out that if we want to avert the 250,000, remember we need to avert about 500,000 new infections every year in this part of the world. But if we want to do just 1/4 of those, we would have to offer PrEP to 25 million individuals in our area. So there is a huge amount of work to be done in this regard. However, we have a problem. The challenges with oral PrEP that we have seen moving into the field is that people are reluctant to take it up and they struggle to persist on it. So taking a pill a day when you are healthy, young, and you've got your whole life to live, apparently is a challenge. And this is where we have to come in to say, what can we do to understand this PrEP use journey, and what can be done to help people actually achieve, consistent use. And some of the work we've done in our unit is to understand these individuals. And it turns out that there are profiles. People, who use PrEP may fall into the category where they need it to be convenient, or they want to be very social, or they want to be entirely independent, or they may be needing discretion more than anything else. And I'm sure there are many other profiles, but it's important to you to recognize that the users each have a personality of their own. In addition, WHO has now really pushed us to say, can we demedicalize, simplify, and really differentiate the kind of prevention services that we offer? So you begin to ask the question, when do I give it? Where do I give it? Who gives it? And what do we give? What else is in that package of prevention services? And this starts to make you think about how we democratize prevention services around the world. And I highlight in the bottom left-hand corner, in Sao Paulo now, they have vendors that actually give out PrEP and don't even need the WHO anymore, because they go to the vendors and get it done. So understanding this conundrum, we started to say, can we give out sexual reproductive health services, particularly for young people, from mobile clinics? And this we've been doing now for a couple of decades. And what we showed during COVID was that the mobile clinics were very important, but when we, in addition, offered to send the PrEP on a courier service, in other words, on the back of a motorbike, to an individual in their home, that this improved delivery and was highly acceptable to people. So this got us to think about, well, what are all the different kinds of PrEP delivery models? And the first thing you have to do is bring together the people who are likely to use it. So we put together a large reference group, more than 80 young people from all kinds of backgrounds, some pregnant, some from the LGBTQI community, etc. And we said to them, what is it that you need to make sure you take up your PrEP? And they said, well, the thing we love doing is fast food. So can it look more like fast food? And we said, sure, we need fast PrEP. And so we designed with them this fast PrEP model, which has as its initiation hub either mobiles or stationary clinics. But in its delivery model of sustained delivery, people can go to their school, they can go to a hairdressing salon, they can get it at a youth club, they can have it couriered to their home, or they can go back to the mobile clinics or the local clinics. So quite extraordinary opportunities. We also realized we needed to let young people know about the service. And so we offered this, increased our demand creation. We knew we needed to reach 1 million people in a single health sub-district. And our target was to get 25,000 young people onto PrEP. And this meant we needed a variety of delivery and a package that would appeal to young people. And you can see where we are now. We've reached 20,000 people in the last 2 years. About 15,000 have now initiated PrEP, 10,000 in mobile, just over 4,000 out of health facilities. But you can see all the various methods of maintenance are well underway. And what we've seen is that when you increase accessibility, when you make it convenient, persistence then improves. So we're starting to see, up to 65, 70% of people coming back for their PrEP because of this. Now, the other way to tackle this is to say, can we innovate around the product? And of course, while we wait for a safe and affordable vaccine or a cure, there is now the innovation of long-acting antiretroviral therapy. And we know in contraception, this has been very important, that when we offer long-acting reversible contraception, many more women take it up and use it effectively, and we get better reproductive outcomes, even in younger women. And so we now have at our fingertips a Depivirine ring, which is a vaginal ring that needs to be inserted monthly. Happy to say we now have a 3-monthly DAPI ring, which gives out the antivirals in the vagina, and this needs to be changed every 3 months. So that's been a huge way forward. We know that it's safe in pregnant and lactating women. The next innovation is injectable cabotegravir long-acting. This is a 2-monthly intramuscular injection. It can be used in men and women and LGBTQI people. And this is injected into the buttock muscle and protects people almost 100%. We know the innovation is coming for a 4-monthly ultra long-acting CAB. This will be intramuscular and will only need to be given every 4 months. And the latest news we heard last year, and this is a trial, we were involved in all of these trials, but this one most exciting last year is the 6-monthly subcutaneous injection, which works in both, again, men and many other women and other populations. And this completely, in young women, abrogated infection completely. So we now have PrEP that really looks quite diverse. As I say, the Depivirine ring, 2-monthly injectable, 6-monthly injectable, and a promise of a monthly pill, annual intramuscular injection, and infusible PrEP all coming. So we can start to think about a menu, but how do you present a menu to people in the field and make sure that they use it? And it turns out from this beautiful piece of real world science that was done in Kenya and Uganda, that when you offer dynamic choice, people are more likely to have their risk covered. In fact, 5-fold more likely to have their sexual risk covered by one of these methodologies, really removing risk of HIV acquisition. So we have inserted cabotegravir long-acting into fast PrEP. We also have a Depivirine ring available in fast PrEP. We haven't been able to offer it to everybody because this type of PrEP has been in short supply. But what we have shown, again, is that people will choose. So young women and girls, about what you can see is almost 3/4 of them chose the Cabolet, 1/4 going with oral PrEP. Amongst male partners, 2/3 choosing Cabolet, And what we also see is that product switching happens frequently throughout time. So people may choose a particular methodology, but then move on to another methodology over time, pretty much like contraception. We also see that continuation is much improved when offered in a long-acting injectable. And we've gone on to ask people, well, why did you not use something like a Cabernet? And we start to get back reasons like it wasn't convenient, it clashed with my work schedule, there was pain at site, I don't really like needles, I didn't like the long waiting times, or my risk has changed. So even here, there is research to help us figure out how we should be using it. Now, Kenya is doing some really nice work to understand whether giving out PrEP and giving prevention in private pharmacies may be a new and effective way of offering. And there are about 5,000 licensed pharmacies in Kenya. And what they've shown is that this is highly acceptable. People really like it, and continuation is good in these settings. And this is showing me acceptability data, which I think is convincing, but also that when it is wedded to contraceptive uptake, so particularly the morning after contraceptive pill, then it is highly attractive and very effective. So you see again women stepping forward using both their contraception and their PrEP. And we similarly have seen in our mobile clinics that the need for contraception draws young women in, and then we can offer them PrEP. And very exciting, there is new technology coming, which offers a dual prevention pill, both contraception and PrEP in a single pill. And this is obviously going to be very exciting. It is being developed by a generic company and hopefully will be available very soon. Now, there is implementation science rolling out around Cabernet, and you can see the many projects around sub-Saharan Africa. I am ringing here the ones that are funded by PEPFAR or USAID. And unfortunately, in the last month, a number of those have been cancelled due to the funding crunch. So this is a changing, and maybe some of our discussions in the future in the chapter will be how we sustain funding, because this is going to be critical. Too often we don't carry out this implementation science in a wide, diverse array of populations. So you can see when you get down to drug-using populations, people in detention, gender non-conforming people, that the projects are much fewer. And so we also need to extend our diversity in who we do projects with. Now, just going back to the need for viral suppression, I do want to point out that we do carry out a sero-neutral approach. So this is another bit of implementation science work we do on the mobile to say, can we reach men to be on their ARVs and virally suppressed? And here we've been using a messaging system, U equals U, to get men, first of all, onto the trucks to test, and if they test positive, to take their treatment. And we're seeing very good outcomes of this very simple message of your life doesn't have to change, you just have to take a pill a day. And moving into adolescence with these long-acting antiretroviral agents, adolescents still die of AIDS because they struggle to take daily antiretroviral therapy. So what we've offered them is injectable CAB and rilpivirine, 2 antiretroviral agents that can be injected every 2 months. And we've had 3 cohorts: adolescents who were virally suppressed, adolescents with poor adherence, and adolescents who were new to treatment. And what they tell us is they love the injectables. For the first time, we have a cohort of almost 200 adolescents who are fully virally suppressed for more than a year. And this is because they really enjoy having an injectable and not having to take pills. So again, breakthroughs of innovation. Now, it doesn't just mean you do the implementation science and it stops there. You have to then really work at access. And we really are in the throes of trying to access these antiretroviral therapies, particularly for young people in our region. So that brings me in the last few minutes to access and availability. We have now about 8 million initiations of PrEP around the world. 2,000 of the vaginal ring, and 25,000 of Cabernet. So we have a very long way to go. This is what WHO and UNAIDS has wanted to see in terms of targets by 2025. So you can see we really are missing those targets. Some of this is around cost and also manufacturing capability. So it has been difficult to get these CAB doses out. There are 3 generic companies now making it, but we expect only 1 million doses in 2026. These are the 3 generic companies that are now making Cabernet, but we also have to be worrying about cost. And so part of implementation science is also thinking about cost effectiveness, and we work very closely with the HERO group. They've been looking at lenacapavir, the 6-monthly injection, and cabotegravir, and you can see the impact that would happen if we were able to use len. Even for 12 to 24 months, we'd see a reduction of almost 40% of infections, and it would bring us to HIV elimination 10 years earlier if we were able to roll out len. So we can probably tolerate a slightly higher price threshold for lenacapavir because of its 6-monthly injection and higher effectiveness for that reason. So we really do want to work on getting the prices down and access. So the work goes on with lenacapavir in terms of clinical trials, but we're also pleased to see that there are now 6 generic companies working on it, and we're expecting the generics to come through in 2027, 2028. Gilead has promised 10 million doses in the next little while, and we expect FDA priority review on the 19th of June, so very, very soon. So, ladies and gentlemen, colleagues, friends, members of the African chapter, I just really want to point out that I think implementation science has helped us to understand that it isn't just about the drug and the modality, but we need to understand the user personality, and we need to understand different methods of delivery. I like to think about it as 3D prep. We need to think about affordability, availability, demand creation, and access for impact, primary prep and secondary prevention. Primary prevention as PrEP and secondary prevention as U equals U, that is taken to scale comprehensively, respectfully, and equitably wherever HIV is circulating, is the key to epidemic control. Effective prevention is most effective when it suits the user and comes with the options for choosing. We will only see epidemic impact when prevention is scaled boldly and all who need art can access so easily and sustainably. Scaling depends on access that is unrestricted, inclusive, and user-friendly. And R&D, of course, should continue because we still have limitations, and we know that lifestyles are varied. And finally, implementation science and health service research ensure that innovation continues and that the innovation gets to all those who need it where they are. And I thank you for that, and apologies for the technical difficulties in the beginning. And I'll stop sharing. Thank you for having me, Shlengiwe.
Wow, thank you very much, Prof. Linda Gale, for such an amazing presentation. Which I just want to, there's so many takeaways. I know that we'll probably have a few minutes at the end, but I just wanted to highlight that it's such a thoughtful and informative presentation. And firstly, it's just a display of the hard work, the innovation, creativity, and the collaboration, and also just including the recipients of the care themselves into the research that you do. I thought that was really, really amazing. And it's also clear that even though there's so much work that has been done, so many achievements, so much excellent work, there's still a long way to go in combating HIV, not just in South Africa, but also in Africa. And I know you spoke about HIV, but most of the things relate to implementation science in general. And you touched also on funding to say maybe we need to rethink the way we were thinking about in terms of sustainable funding, because such platforms in terms of implementation science, bringing researchers and collaboration together, the funding is a big aspect of it, isn't it? And at the same time, we're also talking about the innovative programs that have been found to be effective. How to make sure that they're also sustainable for quite a long time. So that was amazing. Thank you very much for that. I think that it's been very helpful.
Thank you for having me.
Yeah. So Jan Paul, over to you. Thank you, everyone.
Well, thank you very much, Hlengiwe, and everybody who made this event so far very solid, very a lot of dense in lots of insights, lots of thoughtfulness. I think that's what it triggered. But now I have the privilege of inviting 4 people to the stage, all of them professors. Everyone in their own right has experience in implementation science from different perspectives. So I'd like to invite Professor Latifat Imbisomi, who is the head of epidemiology and biostatistics at the School of Public Health at the University of the Witwatersrand in Johannesburg, to the stage. Professor Jamie Lachman, Department of Social Policy and Intervention, Child and Family Global Health, University of Oxford. Professor Themba Gininza from the Department of Epidemiology at the University of KwaZulu-Natal. And Professor Saima Hamid. She is the lead for global health and development and the head of community medicine and public health at the public health department of the Shiva College of Medicine at the Shiva Tamir Millat University in Islamabad, Pakistan. So thank you very much, all of our wonderful panelists who agreed to join us today. I have some questions lined up, but before we start, I would like to invite everyone, all of our panelists, to start us off with, please tell us more about yourself. I had to summarize your impressive biographies, and please share more about yourself and share specifically about your professional and academic journey and about your current work and any focus on implementation science. So I see Dr. Lachman, you are nodding. Why don't I start with you?
Sure thing. Thank you, Jan. So yes, my name is Jamie Lachman. I'm a professor of child and family global health at the University of Oxford's Department of Social Policy and Intervention, and also an associate professor at the Center for Social Science Research at the University of Cape Town. I'm also the Chief Executive Officer of Parenting for Lifelong Health, which is a UK-based charity that grew out of years of research that we conducted on the Parenting for Lifelong Health programs that originated in South Africa and then have now been disseminated in almost 40 countries around the world. I'm a principal investigator of the Global Parenting Initiative and a very proud colleague of Hlengiwe's. We are both co-principal investigators on a series of studies looking at optimizing and evaluating a parenting chatbot in South Africa, both in Mpumalanga and then in Gauteng and KwaZulu-Natal. And really a big fan of the Global Implementation Society. Just, I guess, Jan, do you want more now or should I stop there?
Maybe you can share a little bit about, have you had a focus on implementation science recently?
Yeah, sure. Then I will hand it over to Professors Latifat and Salma. So originally, I did my training in evidence-based social intervention and a doctorate at Oxford in social intervention, and mostly focused on, although my original work was on cultural adaptation and learning about like early stage intervention development and testing, a lot of my postdoctoral work was focused on effectiveness testing, so more in the prevention science and less in the implementation science. But as the programs that we were testing started being adapted for new contexts or being delivered outside of the context of a formal research study, I gradually found myself more and more engaged in the field of implementation science to understand how to transport and embed programs into existing services, what happens after the trial when programs are being delivered in real world settings that are part of everyday routine services. And then also really understanding a lot about how to optimize the delivery or the effectiveness of programs. And so I think that you could say now, while I still conduct randomized control trials, they're mostly either a type 2 or type 3 trial where implementation factors are equally important, if not more prevalent or more important. And it's, I think, a critical issue for us in this time. So my field of interest is mostly in the development and testing and scaling of parenting interventions to reduce family violence, violence against children, and intimate partner, gender-based violence, also to promote child and caregiver mental health and well-being, and to improve child and adolescent development and education outcomes. And those are three elements which are quite critical in the Global South in terms of our ability to achieve our sustainable development goals across multiple targets. And the work around scaling those interventions, implementation science has a very close and critical role to play in that. And I'm learning about how, what are the barriers to scale? How do we look at cost efficiencies? How do we embed programs into existing services? Questions about how, what's the take-up quality and fidelity of delivery? How do you maintain and sustain programs in those services? Those are all moving much more into the field of implementation science. And so those are the questions where we are able to have an impact on reducing the half of the world's population of children who experience violence every year, or the 1 in 5 or 1 in 7 girls or boys who experience sexual violence and sexual abuse in their childhood, or the delayed development in education. We really need to be harnessing the different methods and different approaches through implementation science so that we can have these impact that at scale, and to really be conducting the most efficient and effective research that we can do. Thank you.
Yeah, thank you for your background. I agree with your, specifically the emphasis on scaling facilitated by implementation science. Yes. Professor Ibisomi.
Yeah, good afternoon, good morning, good evening, colleagues. So I'm joining this call from Johannesburg in South Africa. My name is Latifa Ibisomi, and I head the Epidemiology and Biostatistics program at the Wits School of Public Health. I'm also a co-director of an HDSS, that's the Health and Demographic Surveillance Site in Rustenburg here, also in South Africa. I also advise on the implementation science I also advise on the implementation science curriculum from the TDR angle, being one of the PIs from the 11 universities that are coordinating training programs in implementation science under the WHO umbrella. And I also serve on the Global Accrediting Board of DEFINET. That is the body that regulates the field of epidemiology, globally. So in terms of, and just to say before I move to IS that my research focus is actually sexual and reproductive health, particularly on the mother, newborn and child health, and I also do some work on adolescents, and of course some HIV research. So in the last decade, I've increasingly been involved in implementation science work, particularly in terms of curriculum development of training materials, capacity building in general. I also, train, I teach, I supervise, I mentor, postgraduate students in this area. And we also work with partner institutions and with research institutions. We support their work in implementation science. And the good thing is also that at our universities and even other universities around, we find that implementation science is being offered as part of some courses. So the discipline is spreading. The thinking, implementation science is spreading, and people are increasingly embedding this in whatever they are doing. And they want to know more about how this is done. And even as at last week, there was an 8 district in South Africa here, whereby we sent about 8 students to support them, you know, to do certain things, dissemination of kind of research that they did at the various areas of that district, and for them to the students also to support them in carrying out the recommendations from these areas. So it is an increasingly spreading area in South Africa, even among government institutions. We even get invited by the research department of the Gauteng Department of Health, for instance, to train their workers on the implementation science methodology so that they can embed this into what they are doing. And of course, we work closely with the Desmond Tutu Foundation also. Marino is a good colleague that we work together, and they do send even students to us for training. So I think I should stop there. And of course, we work regionally from Zambia, Zimbabwe, and all other areas, So I would say we are doing well in terms of capacity building in South Africa as well as the region in general. And of course, we have, I think maybe we are the only institution that we have a degree, a degree that awards implementation science certificate, at master's level, at PhD level, probably even in the continent or on the continent. Yeah, I think I'll stop there for now. Thank you.
Thank you, Professor Ibisome. Yes, what I pick up is your career so far says capacity building, making sure it doesn't only stay with you. Thank you. Professor Hamid.
Thank you. Well, I am a professor of public health and the team lead for global health and development at Shifata Mir Millat University. Now, I've been working in public health for over 2 decades, and largely, again, in my experience has been in the capacity development. So serving under the Ministry of Health initially, and then moving on into the Ministry of Education as well. I took charge as the Vice Chancellor of Fatma Jinnah Women University, and then Rawalpindi Women University. So working with the health professionals and then with the allied discipline professionals as well. That's, when I was working as a very junior public health professional, I realized that most of the time one is talking about a lot of issues. We know what to do, but how do we do it? And do you get that impact? Was always a big question. And that made me feel that, as a clinician, perhaps, if I had interacted with the patient and the gratification that one would get, seeing a person recover from the ailment, is not coming in the field of public health. And little that I knew, that I transformed over the next decade, realizing that, you can make a larger impact on the populations, provided you use the right kind of skill set. And that is where my journey in the implementation science began. So initially talking about, looking at different frameworks and concepts, from program science to, implementation research, getting involved in some projects funded by WHO implementation research domain, and so on and so forth. Somehow that appetite remained up until the time that I met Dean Fixon, and the way things fell into place was really an awakening aha moment for me and our team, because that's just going through that prolonged engagement with his team, we were able to sort of build up or connect the different skill set that I had learned over a period of time. So as far as the contribution within Pakistan goes, we initially began by implementation of a safe childbirth checklist. It was a known quality tool, very simple, cost effective, and the team showed how just placing an implementation team on ground could make it effective with the high fidelity. So when I moved from the public health domain into education sector, I was again intrigued by the colleagues in other disciplines, and I introduced, we were talking about the same thing, but using different language. So the need for a common language was my take-home lesson at that time. So within a public sector university with limited resources, and with the team that did not believe that with COVID, any online teaching could be implemented with those existing resources. Within a matter of weeks, we were able to full online, launch our Fatma Jinnah online teaching system. So that was the first time that I realized the importance of developing implementation teams. And since then, I've been actively been engaged with the National Academy of Higher Education here in Pakistan, which comes under the Higher Education Commission, where we are working on a women empowerment mentoring program. And on the health side, I'm part of the team that is developing the National Health and Population Policy. And I'm happy to report that, all the experts were of the view that until even at the policy level, we give some implementation guidelines, it would not be functional in a devolved setup such as Pakistan. So this is my brief background of my transitioning from a public health professional from that to a truly implementation science professional now. So thank you.
Thank you very much, Professor Hamid. And I have a follow-up question that I think we can share with everybody, but let's start with you. Seeing that we're talking about a platform of people from various perspectives who come with various experiences, both academically and in terms of their work. But can you share a specific example of a time when engaging with kind of formal implementation science literature or attending a conference directly helped you to avoid reinventing the wheel or provide valuable insights that informed your work that wouldn't have been there if there wasn't such a formalized knowledge base around implementation?
Thank you. That's an excellent question. And I think that aha moment that I talked about, that was my moment, a defining moment, because I had been struggling with these different terminologies when we talked about program science, when we talked about implementation research, operational research, and so on and so forth. And then dealing as a public health professional, am I like, are we talking about the same thing? And are we geared towards, is the thinking aligned to the outcome that we are interested in? So when I attended the Global Implementation Conference in Glasgow a few years back, that was when I met this diverse number of professionals, because earlier on my interaction mostly had been with the health professionals. So although there were lots of health professionals, but there were people from the social welfare, from education, and realizing that we need to build synergies across became so very evident. And I think that has become part and parcel of my personality as well, because if you look at just giving you an example and connecting how things don't end at that aha moment, because today, when we are working towards a national health and population policy, one of the pivotal priority is the multi-sectoral engagement. And we've successfully put that as one of a priority pillar. And not just that, it means we need to create those platforms across those different disciplines and have a common understanding. So this interaction or my exposure at the global conference was indeed a great moment, and I always attribute this success to my engagement with some very fine colleagues that I've been interacting with for the past 5, 6, 7 years now. Thank you.
Thank you. It sounds like by starting this chapter here, we will bring more opportunities like that to South Africa as well. Thank you. Professor Ibisomi, same question for you. What did you learn from literature or maybe from conferences that helped prevent you from reinventing the wheel?
Okay, let me start first of all to what drew me to implementation science. I heard about the concept for the first time in 2014 when we applied for the D43 grant to establish the field of study, at WITS. So when I heard about the thinking behind it, that it is basically meant to, assist us to unbuckle these all sorts of barriers that are there to implementing proven intervention. And I think that makes a lot of sense, to me, especially if we want to get to the desired outcomes that we need. And I think it should be convincing, to anybody that really loves, or that is in the space of public health work. Now, we have been very fortunate that we did not have to reinvent or go back to do a lot of things because we partnered with the University of North Carolina in the application for that grant. And by then, they had a fully fledged implementation science degree going on. So when we got that grant, we sort of borrowed or took a lot of the materials that they were doing there. Yes, we did curriculum development, mapping, and workshop here to see what else we can do in terms of our context. We try to adapt it to our context and also to create a synergy with existing structure that we have here. And we also had the opportunity that for all the core courses, we were co-teaching with faculty from the UNC. So they come over here and we co-teach, we match somebody from here with somebody there to teach all the courses. And we did it for the first 3 years. So that really assisted us. What also assisted us was, officially, the first cohort was 2016. Also in 2015, the TDR rolled out this grant about the postgraduate implementation training scheme. We were also fortunate to win that, to get that grant, which also started in 2016. And we were able to have this, massive cohort of students on implementation science. Then one other good thing that TDR did was to create a platform for all the universities under the umbrella. The platform is called IR Connect. So we all meet, we interact, we share knowledge, we share ideas, we share resources, and we even, assist each other, in terms of maybe I want to do something here in South Africa, I can invite my colleague from Zambia. Yes, Zambia is also part of the network. From Zambia, from Ghana, from Indonesia, from Lebanon, from Bangladesh, to come on board. So those were the kind of support that we got, that we did not have to reinvent too many things, and the platform is still existing to today. We still exchange ideas, we still rub minds, and even all the students that we've trained since 2016, they are now part of the network, so we get bigger and bigger, and all the researchers that have drawn from maybe any grant from WHO or TDR on implementation science are also co-opted into this IR Connect network. So it's a very big platform, and we're able to share resources, we're able to share knowledge, we're able to leverage on each other's strengths. Yeah, thank you.
No, thank you. It's good to hear how you leveraged all the connections and how it had a snowball effect. Yeah, that network impact. Professor Lachman, in your case, do you have something specific that you remember you found or learned somewhere because it was part of a professional way of formalizing implementation science?
Yeah, first of all, I just want to say how much I'm blown away by the work of Osama and Latifat. The inclusive approach Latifat is describing about how to engage and bring in early career researchers into the field of implementation science across multiple countries and contexts. It's just such a wonderful way of like growing a network and community of practice and building the future of implementation science. And I'd like, just like, for me, you know, that's the thing that gets me very excited. I'm seeing more and more students coming to our program at the University of Oxford who are very keen on applying implementation science methods to their research, and I'd love to connect them. Most of them are doing research in the Global South to your initiative, Latifat. I wish that had been the case when I was a student, but I kind of didn't have implementation science, was still growing into the kind of social sciences and moving in when I was doing my my PhD, and they were very siloed. Like there would be a cultural adaptation group, or there would be a group that looks at translational science or evidence of impact. So, but for me, there's actually a specific moment where I went to a conference, and kind of for me, it was like an aha moment, like a road to Damascus type moment. And that is when, so I had been developing and testing parenting programs in South Africa and in the Philippines, and at that point also in Thailand. And we were coming across the same problem where we were getting good evidence of effectiveness of the programs. These are mostly group-based programs that get parents together into a group. They're usually delivered by either social services, or in the case of Thailand, in the public health services, or the conditional cash transfer program in Philippines. And yet they weren't quite fitting into the system, or they were too expensive, or they were too resource intensive or time intensive. And I was really trying to think about, like, what are the methods that I could use to improve the scalability or the applicability of these programs to make it easier for the government partners to take them up. And I was at the Society for Prevention Research annual meeting, I think it was in Washington, D.C. in, I would say, 2016, 15 or 16. And I happened to meet who is now a professor at the University of Amsterdam, Professor Patty Leighton, who I was talking to, and she was like, have you ever heard of the multi-phase optimization strategy framework? And I was like, no, what's that? Well, she kind of flipped over a napkin while we were having a cup of coffee and kind of sketched out on the napkin what a factorial experiment looks like, and how we could maybe use that to start to understand some of these challenges of, like, what kind of level of supervision, or what kind of length of a program, or how much engagement support is necessary to really deliver a program and to support the scaffolding of a delivery. And that kind of changed now, like fast forwarding 10 years now to the present. I've been able to be part of these teams that have used the factorial experiments to optimize interventions in Southeastern Europe, in Tanzania. I see Lauren Barecki, who's been leading a great work around that in Tanzania with an app for parents and of adolescents. Our work that Shingiwe and I do in South Africa with a chatbot parenting intervention, and in Malaysia around preschool delivery. And I think that, for me, if it hadn't been for this conference and this issue around learning about this Linda Collins's multi-phase optimization strategy framework, I don't think I would have been able to harness those skills and those research methodologies. So For me, that is a critical aha moment. But I mean, there are others as well. Like I've been very much inspired by the FRAME IS framework, which can be used to understand planned and unplanned adaptation of evidence-based interventions. And we've applied that now in the Tanzania on the scale up of parenting programs to over 20,000 families, and seeing how it changes and where the changes are in alignment with the evidence and where they go and whether they were planned and who decided and how. And then that framework provides an excellent way of understanding adaptation in the real world. And then also, using the RE-AIM framework has been really helpful as well in understanding scaling of interventions, or the EPIS framework is another one that I'm sure people are familiar with. And then also have students who've applied like the 6 Squid framework to integrate gender equitable approaches into parenting programs to increase male engagement. Of other students who've used community-based participatory action research to really understand the different factors that are necessary when delivering programs for street-connected families. And so I think all of this, the literature as it grows, and I have a growing folder on my computer that keeps on and being shared with different students of the different elements and approaches and applications of frameworks that are really helpful. So I think that one kind of switch on kind of moved me much more into the field of being able to use robust methods to apply implementation science questions. Thanks.
I share your enthusiasm about the theories, the frameworks, yes. And I can already see a theme for the next and maybe the next and many other sessions about the practical adaptation of these frameworks, or whether they were how easy it was to adapt them, to apply them. Now, and there are some people, I know all of you have the title of professor, but you also work with people who are not in academia. And so my question, the next question is about those practitioners who are focused on program delivery. They are focused on the outcome, but what would your persuasive argument be to convince them of the value of incorporating research in general and implementation science, I think in particular, even in a small way, as they plan, as they monitor, evaluate? Shall I start with Professor Hamid? I saw you were ready.
Oh, well, I was just listening to your question, but yeah, I mean, when you're talking to the practitioners, I'm reminded of the time when because I've been into capacity development in the higher education, like my other colleagues. You have to tailor make your sessions or your deliverables in accordance to the audience that you have. So, and I'll give you an example over here. For example, in Pakistan, and I'm sure in the other countries too, universal health coverage is a priority. And in Pakistan, like the general physicians, they offer the primary health care. Using that primary health care approach is the best way forward. Now, in 70% of almost the population, their first contact is their family physician. But so a person that is very acceptable socially to these different people, but at the same time, they don't have the time to maintain the record. So asking them to do research, there are different ways of addressing this issue. For example, our university, in collaboration with the family medicine and again the public health, they've offered a family practitioner's diploma course. But within that, there is a mental health interventions component. Now, the reason why we clubbed that was because if you look at the burden of disease, it's really the mental health issues are on the high, and we have a young population. So you have to look for or make a case for those cost-effective interventions, get their buy-in, and allow the people to see where their contribution on the larger landscape is. So in the introduction, when we take these GPs on board, this is the, this is how they see their role in the larger picture, contributing to the universal health coverage mandate of Pakistan, but sitting in their own clinic, how important it becomes that you gauge the different experiences that they have over there. So embedding it and building synergies with different funding requirements, like even this program, we look for the funder, and their requirement is to provide a little bit of data so that research part or design is done by the Global Institute of Human Development. The implementers are our trained resources, and the geography helps us define how those interventions would impact. Now, these kind of initiatives actually bring the technical knowledge together. They inculcate the concept that evidence-informed decision making is very important, and then to place yourself in the larger picture, where do you position yourself, and what are the implications? Now, whatever data that you generate, is it actually representative or not? And even if it is not, it is still useful for your clientele. So the way I'm describing it, I'm actually addressing some of the key principles of research that need to be inculcated in that training program. Now, some of the people, like say, of the first cohort, almost 70% showed interest in taking on additional courses with us. And when Professor Lakman talked about the practical adaptation of a lot of interventions that are effective, in our particular case, there are certain mental health interventions that can be successfully implemented in, say, school platforms or at the community level. Those are, offered as small, even short courses for these GPs. So this is, again, for them, they are learning a competency. It helps their business, but at the same time, you're learning the importance of some basic core research competencies and applying it. Of course, they're not going to publish in Lancet or high impact journals, but the interest, it is, again, I see it as a phase of training. Some will get interested, they will pursue high degrees, and so on and so forth. And this is how we will build smaller, hubs, so to say. So this is how I look at convincing the practitioners. There, I have seen it happen, like the level of interest being developed, and some of them actually change their pathway altogether, professional pathway, I mean. Thank you.
Thank you. Yes, it makes sense, even for people who want to look at their impact, to start with data and then look backwards of trying to explain it. Professor Lachman,
Sure.
do you have a comment on the same question?
Yeah, like I always think that for practitioners or policymakers to buy into the importance of evidence-based research or implementation research really has to be framed in the interests that they have, or the key performance indicators that they have, and the key outcomes that they're interested in. I think sometimes as researchers, we sit in our academic environments and we think about interesting research questions, but if they're not co-developed and co-designed or done with very close consultation, but ideally with developed with practitioners, we're not asking the right questions sometimes, or not helping ask the right questions. And I really love the kind of research that we've done, where we've actually been hand in hand, where the questions are developed in collaboration with practitioners. When the programs that we developed in South Africa were disseminated throughout sub-Saharan Africa as part of the USAID Dreams initiative, one of the things that we thought we saw an opportunity was to understand what is the real world application challenges and delivery of the programs. And myself and Dr. Shengiwe Sokolo, we were part of what we called the super study, which was the scale up of parenting evaluation research. And one of the first things that we had to do is talk to all the different partners that were scaling the parenting lifelong health programs for young children and for adolescents in the different countries. So like whether that was in Tanzania with PACT Tanzania and all of their local implementing partners, or in South Africa, it was Mothers to Mothers, or in Eswatini, it was PACT again, or Catholic Relief Services in Zimbabwe, is to see, having a conversation about, well, what are the questions that you want to ask? What are the things that you're interested in doing? How can we build the evaluation to be part of routine service delivery? So instead of it just, we're delivering a program, we deliver and we learn, and building that learning culture within an organization in a way that is feasible, which also meant some kind of compromises on the side of the researchers. We couldn't go in and have those long batteries of questionnaires that are asking, using psychometric scales to ask about child behavior, mental caregiver and child mental health, about violence, child maltreatment. We had to create very short scales that could be implemented at the beginning and end of a delivery of a program by a community facilitator. It had to be very user-friendly. And even then, they relied so much on the researchers to do the evaluation. And now that program, that study ended a few years ago. And what we've learned now with technology-assisted assessments, we can also build in the evaluation into the back end of it, so that an implementer or practitioner administering the surveys can have see the results almost in real time, which makes them able to then make real-time decisions on how to improve. If you're being able to track the implementation and the impact of your intervention as it's being delivered, then there's ability to then improve the quality of the delivery, the fidelity, or to understand where extra training or where redesign needs to happen. And I think these are some of the critical elements, are really to make things that are to help practitioners understand the importance of doing research, understanding the importance from their perspective, not from ours as researchers, and then making it feasible, something that they can actually do that is low cost and efficient and integrated into the daily practice, and then building that wider culture of learning. And that is also, the external pressures that come on that, where donors or policymakers want to see those results, so that there is also that value in it as well. Thank you.
Yeah, great point about the co-design and humility. That is important to ultimately be effective and relevant. Yeah, we don't have much time left. Professor Ibisomi, if you have an example of the basically the same question about how to work with practitioners and research, but also if you could think, because this is kind of my wrap-up question, if you could think about the benefits of having for South Africa, an implementation science community. You mentioned the network that you already have there, but if we now with the formalized, I want to bring it back to the GIS chapter, what do you see as potential topics and potential benefits? And I know we already have one topic which we just touched on a little bit with Professor Lachman. As Dr. Becker said at the beginning, we need to understand communities better. So maybe that's one theme that we can have here as to dig deeper into as a GIS chapter. But Professor Ibisomi, what do you think how to handle the interaction with practitioners?
Okay, thank you. Just to say that ordinarily, practices should be informed by research. We know this is not always so. Okay, and like the people that have spoken before me said, it is important to speak to, when you're talking about practitioners, when you're talking about policymakers, maybe other stakeholders in that area, to actually bring them to your corner, to speak to them in a language that they do understand. An example I will give is, like I said, our students work with an 8 districts in Johannesburg here for their practicum. So we use this aspect, the quality improvement aspects, to assist them at some of their healthcare facilities. And we have actually implemented a number of interventions. So one that I can speak to is a particular clinic said they wanted to improve rapid HIV testing for HIV-exposed infants at 18 months. And of course, there are some that they wanted to do something on cervical cancer, and so on and so forth. So what we do is that, first of all, to convince them, we took them through the process of value stream mapping. We also took them through the process of walking the patient's journey, just for them to see how they can look through their system and identify what issues are there, as well as where those issues are. A kind of, what do I call it? Process mapping of whatever process that they're looking at. So we took them through that, and we empowered them to be able to identify what issues that they have and where those issues are. So through that, they started being convinced that actually maybe there's something, in looking at our processes through this particular lens. Then after that, with the examples that we picked 4 clinics with different issues, and we, together with our students, they were able to map out the drivers of the issues that they identified. They were also able to collect data, to diagnose those problems, right? And after that, they were able to sit together to generate change ideas, to prioritize and pick the ones that they think are low-hanging fruits, and they were able to test those interventions and, run PDSA circles. And actually, after 6 months, they were actually able to present at local conferences to present their results. And that actually gave us the buy-in of the entire district. And we've been working with them now. This is like the 7th year. We are still there. So it is important to speak to them in a language that they understand. It is important to demonstrate to them that this is actually something that can work. And that when you actually use research, when you use research to inform whatever intervention or program that you are doing, you are likely to actually get better outcomes for the population that you are serving, as well as for your program. So I think we were able to use that to actually get them into our corner. So that's what I will say about that. So in terms of what can we benefit, by coming together, as a group, GIS group. One thing in South Africa is that we have a kind of enabling environment here. If you know your onions and you are coming with something that is great, you are likely to succeed. The environment is there to support you to succeed. And just like we've mentioned some of the challenges that we have, the first one is the fragmented, fragmented what that we have here. The practitioners are doing theirs, people in academia are doing theirs, the researchers. The left hand does not know what the right hand is doing. We don't even know the cream of people, the universe of people that are doing this in South Africa. I know that there are lots of the NIH grants, around, but we don't even know who those people are. So there's no common umbrella that brings us together, that enables us even to map or to know what is going on. Who can we relate to? Who can we share resources? Who can we collaborate with? Who can we come together so that we don't even reinvent the wheel? So the GIS platform will actually enable us to do that. And of course, when we do that, we know if we promote knowledge sharing, we promote professional development, collaboration, networks, and so on and so forth. Another thing is that we can actually use this as a kind of advocacy, platform. The reason being that implementation science is relatively new, and we discovered that when our students graduate, it's not as if there's any kind of specific implementation science work that they are going out there to do. It's either they go back to what they were doing before, or some are even, they become unemployed because they left to come and study. So maybe this is an opportunity for us actually to be able to advocate, maybe for even these roles to be part of government. And for them, when they come out, they have career progression. They have something to look forward to. They know that, yes, when we graduate, there's something that we are going to. Yes, we encourage them that implementation science is something you can apply even wherever you are, even in your private lives, right? But having said that, and some of them trying to use it and increasingly converting people, getting people, to embrace what they are doing, it would be so nice for them to know that, yes, there's a kind of career pathway, for us when we graduate, because they are there. Yes, there are some research institutions and also maybe some programs whereby you have people that are called implementation scientists. But, this is very, 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 very small and in between. So we can also use this as a kind of advocacy, tool, to get the graduates to do something. And of course, we have to increasingly engage the parliamentarians. Yes, they can actually influence things. So if we have such a body, we can actually all speak with one voice.
Well, wonderful. It sounds like there are real benefits.
Let me stop there.
Thank you. Wonderful. It sounds like there are real benefits to having such a community of implementation science practitioners, thinkers, researchers. Professor Lachman, 1 minute for your thoughts about the benefits of a community like this.
I mean, I think that Professor Latifat has said everything that I would say, the importance of having a community practice, possibilities for advocacy in policymaking. I guess I would just to extend it a little bit to have the ability of this amazing community here in South Africa that could also be extended to others who are working in the region, in the nearby region, but throughout Africa's African Implementation Society as well. And I know that there's a lot of learning that could go around in sub-Saharan Africa. So I believe that this chapter can be also active in engaging with other chapters on the continent, as well as those in other areas, so that we continue to learn. And just one last thing that I would say is, I know that I spoke a lot about different frameworks, but something that I would love to just remind us all as like a last word is that we cannot be slaves to our frameworks. And it's really important also that we understand that the frameworks are theory, and the practice and the application of the frameworks needs flexibility and change. And this is just something that I think for early career researchers especially, we get so trapped into our own frameworks that we don't realize that they are what happens actually in the real world, which is a lot messier and a lot more fun. Thank you.
Thank you. Thank you for that practical reminder. Yes. And Professor Hamid, Pakistan has its own GIS chapter. What can South Africa learn from Pakistan's chapter and the community of implementation scientists?
Thank you for that question. I think I endorse what my other two colleagues just said. there is a lot that you can learn from how we did things in our setting, and so as to expedite your pathway towards getting that group together. It's very important that we build a critical mass of implementation scientists in locally, and then expand, within the region. So I I think for us, what really worked was the fact that we could reach out to the other colleagues within the system, utilizing the resources within the system. And by that, I mean that some of the grants that we secured, we embedded implementation science advocacy within those initiatives. So in a couple of worth mentioning initiatives were in which under the educational capacity building grants, our colleagues actually went out to the other universities, especially in some of the remote areas. And while their research and the teaching competencies requirements were met, additionally, we talked about implementation science, and that's how we looped in a lot of other people from different disciplines. I think one important lesson that we learned was that at that time, the GIS was in the process of still defining how to link up with the regional chapters. So there was a delay which kind of slowed down our momentum in this direction. But I feel that South Africa chapter is at a good position where GIS has a roadmap. So there is ownership at the global level. So globalization would be much more effective now. And I think we will continue to engage even after these sessions, and there will be lots of exchange of learnings so that we can effectively move forward. So what our colleagues did, like we were a handful, but some of the success stories are that within a university, an international conference matured, and in which there were about 90 international professors coming from across the globe. So we had a special session embedded within that conference, and that bridged that gap. So I think we constantly must look for opportunities like that within our system. We don't have to start big. So my takeaway is start small, ask for what works, for whom, and why, and that that curiosity would set the ball rolling, and this would result in meaningful outcomes of all sorts of initiatives, be that research or capacity development, or be an applicability in any other discipline other than health. Thank you.
Thank you very much, our panel. I think the whole session should be prescribed listening material for anybody who wants to embark on being better at implementing. And especially the last points about how the GIS community here in South Africa and in the world, in Africa and in the world, can be beneficial. So thank you very much, Professor Ibisomi, Lachman, and Hamid, for your wisdom, thoughtfulness that you share with us. Good input, good food for thought. Thank you very much.
Thank you for anchoring the program. And thanks for the invite.
Yeah, no, you're welcome. Now, I hope we still have Professor Linda Becker with us. And we also have Professor Naveen Abu-Rumayya. And we also, I think everybody's still here who had the floor at some point. So are there any questions about what you heard from anybody who was speaking? I think we have maybe time for one question. And then we want to make sure that we also share a questionnaire, a short questionnaire with you, just about next steps, how you would like to be involved, thoughts, ideas, suggestions for the GIS South Africa chapter.
There is definitely one question in the chat that I see.
Why don't you read it, Matt, seeing that you've identified it? Thank you.
It is directed at Saima from Sadia. Have you found any Pakistani-driven implementation mechanism in field of public health sector that really goes more okay with our native contextual social layout?
Well, thank you, Matt, for the question. I think, as we discussed, there is a lot of successful models and things happening, but there is fragmentation. So it's important that as we move toward digitalization and move towards development of synergies, Pakistan has is in a special situation where we work under a devolved health system. So as I mentioned earlier, the intersectorality is high on the agenda, and this dialogue at the policy level has been initiated, and hopefully these different models will in due course present their successes, and then we'll move towards scaling up. But since the panel here is largely on the South Africa hub, I would, take this. Well, I mean, if a detailed response is needed, we could do it in a separate session locally as well. So thank you.
Any other questions?
May I have a comment?
Oh,
We have Latifa. Go ahead, Latifa, first.
Thank you, Professor Becker. I just wonder what is the response or the concern of the participants in your study about the safety of the various formulations?
Thanks, Latifa. That's an excellent question and an important one. So we hear repeatedly that side effects and safety is an important consideration, but definitely people put ahead of that efficacy, effectiveness. So, is this going to work? And I think this makes sense in our environment where HIV is such a reality that so many people, face the risk of HIV acquisition. So maybe safety falls slightly lower than I'm going to be protected. I'll put up with some issues in order to ensure this. But safety is a consideration. And so, I think the message to developers is that this needs to be easy, side effect free as well as effective. And so we've struggled a little bit with the vaginal ring, for instance. So the vaginal ring, I know I glossed over the data very quickly, but in the clinical trials that showed only a 30% effectiveness or efficacy, let me put it that way. I think the effectiveness was down because of adherence issues. And so women removed the ring during menstruation, even during sex, which obviously is concerning, but it speaks to some of the, the inputs that we've heard this evening about gender-based violence and intimate partner violence, etc. So women removed the ring during their sex. So definitely, effectiveness is up there, but safety comes close behind. So all of these factors need to be considered. And then, as you heard, convenience. When you're healthy and you're doing this, you're not sick, you're not needing this medication, then convenience is really important.
Thank you.
yes, Naveen.
Thank you very much. And I just wanted to say that listening to the different panelists and presentations, it just highlight the importance of having South Africa chapter and other chapters in Africa, and hopefully by the end we will get Africa Hub. but there are lots of opportunity actually to start with. So you have the network in the universities, you have experts here in the field in South Africa, in different regions. So once you come together, I think things will become easier. But the point that was mentioned by Latifa, which is the fragmentation, I think this is not a problem only in South Africa. This is a problem everywhere. And Dr. Saima also has mentioned it. So you have identified the different challenges you are facing, but also you have identified the potential that will lead to a successful South Africa chapter. So I think what this discussion is very, very informative and useful for us, and I can see a very bright future for it. So I'm using the GIS hat now, putting aside other places, but I would say that the collaboration also with Oxford, with the expertise they have, the network they have, I think you will have a very successful start. So I wish you a very good luck.
Well, it is exactly 5 p.m. in Cape Town, South Africa, where I am at the moment. So this shows that we can do things very precisely. We can implement a 2-hour meeting within 2 hours, which is perfect. I want to start off by thanking Matt and Peggy for the support of Global GIS, and my partner in crime, Hlengiwe Ngwebu. Thank you very much for helping. We helped each other with the support of Matt and Peggy. So a wonderful partner. Over to you. You started the meeting. Hlengiwe, over to you.
Thank you very much, Jan Paul. I think you've said everything. Mine is just to thank everybody, especially the amazing speakers. I love how the talks were just feeding to each other. I think it was an awesome, awesome time. I mean, thank you very much, everybody. Your presence here signifies the shared commitment that we have in seeing implementation science established and grow in South Africa and in the African region. Of course, I think it will actually get into that. But together, I believe we can create an environment where implementation science can truly thrive. So for me, it's cheers. And cheers to what lies ahead. Thank you very much, everybody.